very good morning, distinguished guests, ladies and gentlemen. Welcome to our morning symposium of diabetes for the second day of the IDEC. So I will be chairing this session as a co-chair together with my teachers, Chairman Professor 𝗕𝗏𝗯𝗧𝗏𝗧𝗏𝗧𝗏𝗏𝗧𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏 speaker. First speaker is Professor Leilani 𝗏𝗏𝗄𝗡𝗖. She received her BS Medical Technology and Medical degrees from the University of Santo Thomas in Manila in 1977 and 1981, respectively. She received her doctorate degree in Endocrinology and Metabolism in 𝗕𝗵𝗆 School of Medicine in 𝗕𝗵𝗆, Japan in 1992, and master degree in public health in University of the Philippines Open University in Manila in 2010. She completed masteral studies in distance medical education, major in instructional design in 𝗕𝗲𝗆𝗀 University in Canada in 2020. So she will be talking actually pre-IGT and beyond medicine, decoding intermediate hyperglycemia. And then may I respectfully invite the Professor Leilani on the stage, please. Ladies and gentlemen, please welcome Professor Leilani.
Thank you very much for the kind introduction, my chairpersons, Professor Coco and Professor Khin Maung. Congratulations to your second International Endocrinology and Metabolism Congress. I love your Congress very much, and with my friend Professor Tantanay. And I love Myanmar. This is my third time in Myanmar. I'm so impressed with the beautiful ladies and the handsome gentlemen. Today, you will hear for the first time something that I characterized in the field of diabetes. You probably wonder why every time somebody will talk, they will show you increasing incidence of diabetes all over the world. Because I think we're starting to recognize a metabolic disorder very, very late. I will introduce to you an entity called pre-IGT. For clinicians who are practicing, it's very, very easy to understand because it is a stage before IGT. I will show you how it is diagnosed. I have characterized it for the past 20 years. I will show you serious risk factor for cardiovascular disease and challenges. And I have shown how we projected pre-IGT in the Philippines in the next 5 years. And now, our government has recognized that we have to study and survey the Filipino pre-IGT prevalence. In our book, it says there are 2 risk factors. One is family history, genetic, and the other one is lifestyle. Because of that, there will be insulin resistance, and then hyperinsulinemia develop. In the book, it says compensated insulin resistance, where the pancreas is still healthy. For me, as a clinician, I can understand it better if I put the word pre-IGT. So in 2003, I started using pre-IGT in my researches. How do we diagnose it? We can only diagnose it with insulin measurement, not blood sugar. Because at this stage, the pancreas is still compensating effectively so that the blood sugar is still normal. And what comes down after that is what ADA is showing all about it. It's the IGT and the type 2 diabetes, which everybody knows. Let me clear some terminology. In the published papers, they call it pre-diabetes, pre-diabetes. But for me, look here, if you have two parents who have type 2 diabetes, even if you are still in the womb of your mother, you are in a pre-diabetes state. So I don't use that. But if you look at this depiction of course of metabolic problem, you can see that after normal and before IGT, there is a stage which I call pre-IGT. So from normal C to IGT, that's pre-diabetes. It's a very, very wide area. But for pre-IGT alone, it is the stage before IGT. For us who are in the clinics, it's very easy to understand. So how is it diagnosed? We are familiar with two techniques. One is the OGTT, which is friendly in our clinic. The other one is insulin pump technique, which is research-based. I'm so happy when I saw the group of Istanbul et al., where they showed the relationship between the insulin clamp and the OGTT. When they looked at it, they have shown a very, very high correlation of OGTT and the clamp, 0.8 to 0.78, 0.79. So what does it mean? It means that mere OGTT alone, we can diagnose insulin resistance. Similar studies have shown that the first or fasting and the second hour of OGTT, with this level of insulin in the second hour of over 45, you can already say that the high-risk individual, remember that, there should be risk. So the high-risk individual can be diagnosed with hyperinsulinemia. Others have used the index reference and the 120-minute. But in my researches for the past 20 years, I'm using the second hour insulin level. Now, the question is, which one should I use, Dr. Asis? There's no problem. If you want to use the fasting, fine. If you want to use the second hour, fine, insulin level. It depends which area of sensitivity of insulin is being tested. If you are using fasting, you are testing the sensitivity of insulin on the hepatocytes to tone down gluconeogenesis and glycogenolysis, fine. But the problem is, what if not only hepatocytes, but some other tissues have insulin resistance? So I use the second hour insulin post-OGTT, where sensitivity of insulin is tested in the muscles and fat cells. So how do we diagnose it? We have to look for the suspects, okay? Obesity, even if there's no family history, very strong. PCOS, I tell you, PCOS, later you will see that the insulin resistance in PCOS is equivalent to the risk, cardiovascular risk of type 2 diabetes. GDM, and people who show acanthosis nigricans. So what I do, I have already the orange in my clinic. If I have a high-risk individual, I give it to them, and I instruct them to have an overnight fast, and then they drink it at 6 o'clock in the morning. They go to a laboratory, 7:30, there's a 30-minute rest. And then I write in the instruction to extract blood at 8 o'clock. So there's a 2-hour OGTT test. The first publication was 2009 in Philippine Journal of Internal Medicine. You know, it does not go through any international because pre-IGT is Asian, and it's not accepted in the early stage of this study. So here I was able to show of 117 patients that there are a group of people, there are a group of high-risk subjects who have still normal glucose based on ADA criteria, but a very, very high insulin. A very high. If you don't check the insulin, you will miss these people. So, pre-IGT is defined as elevated insulin with normal glucose based on ADA criteria. Remember that. It's the ADA who gave us the criteria. And then it's like a Bible to us. Whereas IGT is already where pancreatic fatigue is starting to ensue, so that glucose is starting to go up because the compensatory insulin is not working anymore, okay? So what does it mean? It means that if we hit the pre-IGT stage in our management, probably we can decrease the prevalence of type 2 diabetes in the future very, very significantly. I just wanted you to review, and you know it very well. You have a one-day conference yesterday, the diagnosis of diabetes based on blood sugar. Based on blood sugar. So intermediate, as my title says, is impaired glucose tolerance, fasting blood glucose, OGTT, but it is a blood sugar measurement. Next. When I was doing the researches on pre-IGT, everything came by a surprise. I didn't know what to expect, but I did it anyway. First, I would like to show you who are those people we have to look for and tested. These figures are from the endocrine textbook, and Ferranini is probably a student of Dr. 𝗕𝗏𝗯𝗲 because it's their team. They have shown that obese but non-DM patients will give you high insulin as well. So all obese, from children down the line, should be tested. Next, obese and IGT will give you high insulin as well. So hyperinsulinemia in IGT after OGT will give you, and this is a given thing. Non-obese but diabetic will also give you hyperinsulinemia. So these are the people. That's why sometimes, especially during summer, I see patients with their children with them. If I see, and they are on the right age, or obese children, I encourage them to do the test. So our team started to characterize this stage of metabolic disorder, and this is our history from 2003 to 2023. First, I thought, hey, this is very early. Probably this is just subclinical. So 117 patients, we again tested, and then arbitrarily, we give points. 7 points for BMI, and these are the official risk factors by Diabetes Care 2006. BMI is 7, family history is 6, age of over 40 is 5, male gender is 4, hypertension 3. And then, if it is a female, I added 2 points for PCOS and 1 point for GDM. You know what I got? The normal and the pre-IGT have the same score. It's statistically different from IGT, and it means that they don't have yet so much hypertension, okay? And then you can see here, the one that I'm telling you, the high insulin between the normal and the pre-IGT. And then as the blood sugar goes up, you can see that the insulin is coming down. So again, it's given, but this is the first time visually you can see it. But what I noted is, so pre-IGT at that time, it was 2009, I said, hey, probably this is a clean stage of metabolic disorder, clean of complications. But I was shocked when I saw that PCOS and GDM against the normoinsulinemic is already a statistically significant high score, and probably they are already hypertensive. It's the insulin level that is a factor. I will show you there. So PCOS and GDM history in my study are shown to be diabetes equivalent. So you have to be very, very aggressive on treating their hyperinsulinemia. So, and then we pulled this out from publication before because I was really doubtful of my results. It has low negative predictive value in the population, the prevalence in the 117 patient is 52. It's very high. Probably in this room, we're over 50 who have in pre-IGT. The low negative predictive value says it's subclinical entity. Until then, we went to another area of checking the effect of pre-IGT, and that is the liver. Looking at the liver, we saw that the pre-IGT subjects have higher incidence of fatty liver. So it's not at all subclinical. This is another entry of testing those people with fatty liver. And although statistically not significant, they have higher insulin level, those with fatty liver, than those without fatty liver. This is a very classic publication. Although it is locally published, I correlated the glycosylated hemoglobin with the glucose and insulin. So we have group of people who have normoinsulinemic, and then group of subjects with hyperglycemic but hyperinsulinemic. But in the ADA, they are both normal. So the second-hour insulin have shown, just like what I'm showing earlier, that the insulin level is statistically very, very high against the normoinsulinemic. But what is shocking for me is the blood sugar. When you look at the blood sugar of those normoinsulinemic, it's very effective because the sugar is 90. So the insulin sensitivity to the peripheral tissue is very, very effective. But the pre-IGT is already showing something, a statistically significant difference. So even if the ADA will say 120 is normal, it's abnormal because pre-IGT people will have effect already in the endothelium. I will show that to you later. So this is the challenge, that in the ADA classification, the normal is less than 140, but pre-IGT cannot be caught. We cannot catch pre-IGT in the ADA classification at all because they are inside the less than 140. Okay? And the 𝗵𝗵𝗯𝗃, you know, people with normoinsulinemia 5 is the normal. And then, now I see people, I don't test at all. I don't test them any at all with OGTT. If they have high risk factors and they have an 𝗵𝗵𝗯𝗃, I treat them right away. I don't go to OGTT anymore because 6 is the pre-IGT level. So if you're using the 𝗵𝗵𝗯𝗃 in the ADA, you can catch them in the pre-diabetes level of ADA. So my study conclusion then was the pre-IGT groups have significantly higher blood sugar, insulin, and 𝗵𝗵𝗯𝗃 levels than normoinsulinemic group. Aggressive treatment must be initiated. This is the challenge as early as the pre-IGT stage. Delay in the pharmacologic treatment is a problem when we use the ADA classification. So now let's go to the challenging part. Again, this is another surprise to me. I'm not expecting anything. When I think something and I do research on it, I'm not expecting anything. And they are come by surprise. So I said if there's relative hyperglycemia, therefore, it is not totally subclinical. So let me look at the endothelial dysfunction. So endothelial dysfunction is very easy. If you have a 2D echo area in your hospital, you just do it, and then it's inflation, and if there is the dilatation afterwards of the brachial artery does not go beyond 10, then there is dysfunction, okay? After inflation, there should be dilatation. So in the previous report, the FMD or flow-mediated dilatation in type 2 diabetes and IGT are very, very low, less than 10. It had been reported. It's there all over the papers in the literature. We did 2 first. We did 2 earlier in 2015. And we saw that they're still okay. And I said, I had a breather there. Pre-IGT can be saved from cardiovascular. But when I continued the work in 2023 and more patients got in to the research, unfortunately, we found 22.6% already with abnormal endothelium in the pre-IGT stage. And you can see which are the risks of these people that will lead them to the endothelial dysfunction. So with that report, we were able to show this graphic that for every 1 unit second hour insulin increase, there will be 1.0% decrease in the FMD. That's the association. And for 1 unit HbA1c increase, there will be 0.38% FMD. You know what this means? That the hyperinsulinemia is more dangerous than the hyperglycemia at the pre-IGT stage. Look at the percentage of decrease in the FMD. So, in the past, in healthy individuals, they have shown the femoral artery, when given insulin for several hours, the dilatation comes down. Also in the brachial and femoral and brachial artery, they have shown already. So if that is the case and endothelium is affected, then the one that is now in danger is the cardiovascular system, because majority of the cardiovascular system starts with an endothelial dysfunction problem. So here, how does a hyperinsulinemia lead to cardiovascular? You know, when I was starting my, when I was in my training and I was starting as a young consultant, I was already thinking of high insulin into the blood vessel. So, you know that, yeah, I got it in my cell phone. You don't need to march. So hyperglycemia will lead to oxidative stress, epigenic changes, inflammatory cytokines. And then it had been shown in the past that hyperinsulinemia indeed will lower endothelial-dependent vasodilatation. In the 𝗵𝗠𝗀 syndrome of insulin resistance, he showed already in 1991 that hyperinsulinemia will lead to atherosclerosis. And he predicted that hyperinsulinemia will lead to proliferation of smooth muscle cells, stimulation of connective tissue synthesis, and stimulation of growth factors. So what is the culprit? What is the culprit and who is the culprit in hyperinsulinemia? C-peptide. There is an equimolar of insulin with a C-peptide that is cleaved off to make the insulin active. So increased insulin is a primary characteristic of insulin resistance. Therefore, there is hyper-C-peptidemia in insulin resistance, and C-peptide is atherogenic. C-peptide can invite some chemotactic substances and then lead to the proliferation of smooth muscle. I will show you 3 phases. One is looking at the C-peptide in the Petri dish, in the animals, and in the human being. So in the Petri dish, human and rat cell proliferation with increasing dose of C-peptide, they have already shown that proliferation is indeed happening with C-peptide as it is compared to platelet-derived factor, which is very, very notorious for smooth muscle proliferation. So when they injected C-peptide for 2 weeks in rats, they were, and then they killed the rat, sacrificed the rat. They showed in the aortic arc increased inflammatory cells, increased SMC proliferation, and increased lipid deposition. So the fronts have shown that those with hyperinsulinemia obese have hypertension early than those without hyperinsulinemia. In the NHES study in the United States, over almost 4,000 people have shown myocardial injury as the C-peptide increases. So here they've said that the circulating C-peptide increased 1.48-fold risk for myocardial infarction, and it is a new risk factor for SCMI. This is very important. This is already in non-diabetic women. They group them into group 3, those without cardiovascular risk, without CAD, and then they look at the second-hour blood glucose, insulin, and second-hour insulin. Group 3, everything was normal. Group 2, they have risk, but they have no coronary artery disease, but the fasting insulin is showing high. But in group 1, they have cardiovascular risk, they have coronary already. All the biochemical parameters are very, very high. And this was duplicated by the group of Cabrera de Leon. Group 1, no insulin resistance, but group 2 has insulin resistance and almost 3 times risk for myocardial and coronary artery disease. In children, I just wanted to pass it through. Acanthosis nigricans is a very, very red flag for children. They have shown already carotid intima media thickness. Okay, in our pre-IGT with endothelial dysfunction, what we saw in the characteristic of patients with positive FMDR, they are older, they are more obese, they have higher HbA1c, total cholesterol, and LDL, had a longer duration of being overweight and obese, and a longer history of PCOS. So I have implications and challenges. I have shown you that there is, if you don't measure insulin, you cannot catch them. If you don't measure blood glucose, if you don't consider 128, you cannot catch pre-IGT. And not all will have the phenotype. So just one phenotype is enough to test the individual. And then start a pharmacologic. If you don't test the insulin, you cannot start them early enough. So what does it mean? If you started them as IGT, you combine metformin and lifestyle, for 30 years, you can decrease overt type 2 diabetes. But if you use pre-IGT, you can increase the number of people that will be prevented to have overt type 2 diabetes in the years to come. So we projected based on our population. So I have the time, I'm just probably asking 3 more minutes. I have already time, Mr. Chairman. Another 3 minutes, okay. So I'm finishing up. So based on our population, for every 4 pre-IGT not treated, there will be 2 who will develop IGT and 1 with type 2 diabetes. And then if we project that to 2030, there will be 20 million Filipinos with type 2 IGT, 40 million IGT, and 80 million pre-IGT. Even if there is 80 million pre-IGT, you can see the costs of burden, because pre-IGT is only metformin or pioglitazone and lifestyle, whereas type 2 diabetes is polypharmacy. So the amount of socioeconomic burden is 4 times with type 2 diabetes. So now we're doing a survey in the Philippines. This is a 2023 national survey actually. They're using still the ADA for classification, but I introduced to them the pre-IGT. So we are doing it in the biggest region of Metro Manila, which is NCR. We are now 6 of the 17 areas, 536 samples of 1,694, all urbanized barangays. Probably the next time I'll be here, I'll show you already the prevalence of pre-IGT in an urbanized barangay in the Philippines. So this is my summary. Pre-IGT is the earliest stage of type 2 diabetes compensating insulin resistance. Family history, obesity, history of GDM and PCOS are risk factors. Increased circulating C-peptide lodging onto vascular smooth muscle leads to cardiovascular problem. Adverse CVD outcomes is due to the long-standing hyperinsulinemia. So our group has characterized it, red flags, obesity, PCOS, and it's now a serious challenge to have a robust approach for for high-risk individuals with insulin resistance to have timely assessment and management. And that will give the country a socioeconomic unburdening of the metabolic disorder. This is my last slides. These are my collaborators. Thank you very much for your kind attention.
Thank you very much, Prof. Leilani, for sharing the knowledge about pre-IGD. So the Q&A session will be after the end of the two speakers. So please come and join us on the stage, please.
Good afternoon, ladies and gentlemen. I'm Surin from Seoul University College of Medicine. Today, I will be discussing the role of 𝗫𝗏𝗃 in preventing atherosclerotic cardiovascular disease, particularly in patients with diabetes. Let me start my presentation with this slide showing the leading cause of death in the world. According to this WHO data, cardiovascular disease, particularly ischemic heart disease and stroke, remain the leading cause of death in the world. These conditions share common underlying mechanisms, including atherosclerosis or oxidative stress. This emphasizes the urgent need for effective preventive strategies, especially in high-risk populations such as people with diabetes. In the formation of atherosclerotic plaque, which is the starting point of atherosclerosis, several factors are involved, such as increase in adhesion molecule, the involvement of oxidative stress, foam cell formation, or migration of smooth muscle cell infiltration. But among these, two main players are there: lipid deposition and aggregation of platelet. For lipid deposition, we should prescribe a statin, and we also need antiplatelet agent to prevent or mitigate aggregation of platelet. In clinical practice, there are four antiplatelet agents such as aspirin, sapoxylate, 𝗫𝗏𝗃, or clopidogrel available. Among them, aspirins have been widely used across the globe. However, recent large-scale trials such as ASPRI, ARRIVE, and ASCEND have questioned aspirin's role in primary prevention, especially in population without established cardiovascular disease. When you look at these study results, the modest benefit in terms of CV risk reduction, which are often outweighed by risk of side effects such as bleeding risk. For example, when you take a look at the ASPRI study on the left-hand side, aspirin did not reduce MACE, which is composite outcome of myocardial infarction, stroke, or CV death, but increased major bleeding risk by 38% and surprisingly increased all-cause mortality by 14%. Based on these detrimental findings, many guidelines for aspirin use have changed dramatically. Actually, it received A level in the recommendation for CV prevention in 2002 USPSTF, which was a former official organization supported by US government. But it decreased to level 3 in ACC/AEH 2019 guidelines. So they recommend not to use aspirin for patients over 70 years of age or with high bleeding risk. This is where 𝗫𝗏𝗃, another antiplatelet agent, may offer advantage with the evidence suggesting efficacy and more favorable side effects. Let's now turn to the specific mechanisms of 𝗫𝗏𝗃. This slide shows mechanisms of four antiplatelet agents to their role. First, aspirin. Aspirin may mainly act by inhibiting the thromboxane A2 production, and 𝗕𝗏𝗆𝗆, the commonly blocked ADP, which is called ADP modulator, and 𝗕𝗏𝗆𝗆𝗃 is a serotonin inhibitor. Serotonin is 5-HT2A. Different from these three agents, 𝗫𝗏𝗃𝗃 is a phosphodiesterase 3 inhibitor that increases intracellular cyclic AMP, leading to platelet inhibition and vasodilation. Actually, 𝗫𝗏𝗃𝗃 shows very high selectivity for PDE3, particularly in platelet, cardiac muscle, vascular smooth muscle cell, and adipose tissue. This selectivity is key to its targeted antiplatelet and vasodilatory actions, while minimizing effect on other PDE families, such as PDE4 or 5. Let me introduce a couple of the in vitro studies suggesting beneficial effect of 𝗫𝗏𝗃𝗃 on vascular system. The first, the in vitro studies on vascular endocellular cells shows that 𝗫𝗏𝗃𝗃 treatment significantly increases the nitric oxide production in a dose-dependent manner. As you know, nitric oxide, or NO, is a potent vasodilator and emitter of platelet adhesion, playing a central role in vascular health. In clinical cases, 𝗫𝗏𝗃𝗃 treatment has demonstrated improved blood flow in peripheral arterial occlusive disease. In this patient with occlusive vascular disease around ankle area or knee area show measurable, meaningful increase in perfusion after 6 weeks treatment of 𝗫𝗏𝗃𝗃. Actually, these improvements are clinically meaningful, often translating into reduced symptoms due to intermittent claudication or better functional capacity, such as increase in gait speed. 𝗫𝗏𝗃𝗃 also reduces reactive oxygen species, or RS, production in endocellular cells. By decreasing oxidative stress, it prevents further endocellular injury. This antioxidant property is particularly beneficial in diabetes, where oxidative stress accelerates atherosclerosis. Another unique benefit of 𝗫𝗏𝗃𝗃 is favorable impact on lipid metabolism. 𝗫𝗏𝗃𝗃 stimulate lipoprotein lipase activity, which is the most important enzyme in lipid metabolism. This leads to reduced TG lowering and increased HDL cholesterol. This is another advantage in diabetic patients, where dyslipidemia is a major contributor to cardiovascular risk. Now I am going to introduce a couple of clinical studies with 𝗫𝗏𝗃𝗃 on development of atherosclerosis. The first study that I'm going to introduce to you is the 𝗕𝗃𝗃𝗃 study, which was conducted in Japan and other East Asian countries. They recruited East Asian patients with type 2 diabetes. For this study, the 329 participants with type 2 diabetes and atherosclerosis were enrolled, and they were randomly assigned into aspirin group and 𝗫𝗏𝗃𝗃 group. This was a 2-year study, quite a long study, and they measured carotid IMT, intima media thickness, in both left and right common carotid vessels. They found that aspirin treatment, as shown in blue, did not reduce the progression of carotid IMT, whereas 𝗫𝗏𝗃𝗃 treatment, as shown in violet here, decreased carotid IMT thickness. As we are all aware, carotid IMT is a well-recognized surrogate marker for cardiovascular risk. Its reduction has important prognostic implications. The next study is a Korean study. In this study, we used the 3-dimensional ultrasound to assess development of atherosclerosis in the carotid vessels more comprehensively. And this is an example of how to measure carotid IMT with three-dimensional probe. It is recommended to measure carotid IMT at 3 points on the upper right-hand side, bulb area, and ICA and CCA areas. As shown here, more than 1 millimeter in carotid IMT is commonly defined as increased carotid IMT, indicating initiation of atherosclerosis. This patient showed 1.17 millimeter, which means the patient have the early phase of atherosclerosis in carotid area. This is another example showing around 40% occlusion in right common carotid artery in a patient in my clinic. So we have to treat this patient with antiplatelet agent more actively. For this Korean study, a total of 50 patients were recruited, and we divided them into 2 groups, silostazol and aspirin. After 6 months, the carotid IMT with the three-dimensional probe was reevaluated. In this study, we found that carotid IMT progressed in the aspirin group in dotted lines, whereas the silostazol group prevented it, resulting in significant between group difference. Intriguingly, when we compare the efficacy of silostazol on carotid IMT between Japanese study and Korean study, we found that it was more efficacious in the Korean study. Why? We think that this difference came from that sustained release formulation of silostazol, SR form of silostazol was in the Korean study, such as Platel SR, but immediate release formulation was used in the Japanese study because it was conducted in quite a long ago, 15 years ago actually. As you know, SR type of silostazol had very low adverse event than IR type of silostazol. So we could use 200 milligrams of silostazol fully in almost all participants, but it was not in the Japanese study. Silostazol also have beneficial effect on cerebral vascular blood flow. In this patient with chronic cerebral infarction, silostazol treatment improved cerebral blood flow on SPECT imaging after 3 months. This improvement is likely due to enhanced vasodilatation due to increased NO secretion by silostazol and reduced platelet activation and endocellular benefit induced by silostazol treatment. Another study compared the silostazol to placebo for secondary stroke prevention. The relative risk reduction, as shown here, were particularly notable in patients with diabetes. Actually, there was a 1/3 lower risk of stroke recurrence in patient received silostazol compared to placebo. So this is why silostazol is strongly recommended to patients who already experienced a stroke, because silostazol treatment can decrease the second attack of stroke. Let's now review coronary artery outcome, which was obtained from the ESCAPE study. Actually, atherosclerosis develops not only in carotid or brain system, but also in heart, in coronary vessels. It was reported that more than 70% of patients with diabetes with increased carotid IMT have coronary artery stenosis. So this is the reason why we sometimes should check the coronary vessels in patients with carotid stenosis. Based on this, we wanted to confirm the efficacy of 𝗕𝗏𝗪𝗏 on coronary artery this time. We named this ESCAPE trial because it has the meaning that we wanted to avoid our patient from the coronary attack, such as MI. The ESCAPE trial randomized patients with type 2 diabetes in my clinic, and we gave them SR type of 𝗕𝗏𝗪𝗏 200 milligram in one group, and the other group we prescribed aspirin 100 milligram once daily, which was randomly divided. In this study, we used advanced technique, advanced coronary CT scan, as shown here, which enabled us to assess detailed changes in the plaque composition and degree of stenosis in coronary vessels. For this study, a total of 100 participants were recruited and divided into two groups, a 𝗕𝗏𝗪𝗏 group and aspirin group. And after 12 months of treatment, multi-detector CT, cardiac CT were rechecked. In baseline characteristics, mean age was 66 and 62 in 𝗕𝗏𝗪𝗏 and aspirin group, respectively, and the mean BMI was around 25 in both groups. I'd like to highlight their lipid profile here. Their lipid levels were all well controlled with lipid-lowering medication. The reason why I highlighted this is the aim of our study is to investigate the efficacy of antiplatelet agents such as 𝗕𝗏𝗪𝗏 on top of standard care of lipid medications. Here are the results. After 1 year treatment, we found that coronary artery stenosis progressed in the aspirin group, whereas 𝗕𝗏𝗪𝗏 group decreased coronary artery stenosis in the maximal coronary stenosis and non-calcified plaque volume. As you know, there are two types of plaques, calcified plaque and non-calcified plaque, and non-calcified plaque can be categorized into more vulnerable plaque. So decrease in non-calcified plaque volume by 𝗕𝗏𝗪𝗏 has clinically important meaning, I believe. The overall, this slide shows adverse event, and overall 𝗕𝗏𝗪𝗏 were well tolerated, with most common adverse effect being mild headache, which was expected from the study design. Importantly, there was no significant increase major bleeding in the 𝗕𝗏𝗪𝗏 group here, but two patients experienced major bleeding in the aspirin group, and actually they exhibited a massive GI bleeding, and they were sent to emergency room, and I was a little concerned about this, the safety, but fortunately the ER doctors managed them well, and they were returned to the study. So I was very relieved by that. Anyway, aspirin, when we prescribe aspirin, we have to always concerned about the increased risk of bleeding. And the second most common side effect of 𝗕𝗏𝗪𝗏 is heart rate increase. However, this is only 3 to 4 beats per minute, remaining within safe limit. So we don't recommend 𝗕𝗏𝗪𝗏 to patients with severe heart failure patients, except that we can prescribe 𝗕𝗏𝗪𝗏 with safety. Next, I'd like to introduce a meta-analysis paper with the 𝗕𝗏𝗪𝗏 trials, which was published recently. We meticulously checked the 𝗕𝗏𝗪𝗏 studies on the PubMed, and we found that approximately 500 papers with 𝗫𝗏𝗪𝗏. And among them, we selected 33 randomized controlled trials evaluating 𝗫𝗏𝗪𝗏's effect on cardiovascular outcomes. We checked the efficacy and safety of 𝗫𝗏𝗪𝗏 compared with placebo or antiplatelet agent, other antiplatelet agent in this review paper compared with placebo or control. On the left side, 𝗫𝗏𝗪𝗏 reduced MACE, major adverse cardiac event, by 41% without increased bleeding risk. How about comparing with other antiplatelet agent? When I compared with other antiplatelet agent, 𝗫𝗏𝗪𝗏 reduced MACE by 21%, but which was reduced, the degree was decreased, but still statistically significant. What about the bleeding risk? There was no difference in bleeding risk between 𝗫𝗏𝗪𝗏 and control group or placebo when compared to active drug, which included aspirin, saporilate, or clopidogrel. The 𝗫𝗏𝗪𝗏 showed significantly lower bleeding rate, such as more than 47% lower risk of bleeding compared to active drug. This is mainly due to aspirin use. Aspirin increased the bleeding risk by 30% or sometimes 40%. So these findings support the broader use of 𝗫𝗏𝗪𝗏 in high-risk patients with diabetes or metabolic impairment. Let me summarize my talk today with this slide. 𝗫𝗏𝗪𝗏 appears to shift from a vulnerable plaque phenotype characterized by thin fibrous cap and platelet activation here, lipid deposition, calcification, foam cell formation, and intraplaque hemorrhage. After 𝗫𝗏𝗪𝗏 treatment, we can expect more stable plaque, such as thick fibrous cap, lower lipid core, less involvement foam cell. So the favorable effect of 𝗫𝗏𝗪𝗏 can be mediated by several different mechanisms, such as vesicular endocellular stabilizing effect by NO production from 𝗫𝗏𝗪𝗏 treatment, and platelet activation stabilizing property by 𝗫𝗏𝗪𝗏, and the TG lowering efficacy also contributes to less development of vulnerable plaque, and the vascular endothelial smooth muscle relaxation also involved in the better the vascular health. So there are several different mechanisms which are involved in the better or favorable result of atherosclerosis progress with 𝗫𝗏𝗪𝗏. The last but not least, I'd like to provide you a more important tip for 𝗫𝗏𝗪𝗏 prescription in daily clinical practice. For patients requiring invasive procedures such as biopsy or operation or surgery, 𝗫𝗏𝗪𝗏 must have 2 to 3 days washout period. This is way shorter than for many other platelet agents, which requires around 7 days or sometimes 10 days. So in an emergency situation, 𝗫𝗏𝗪𝗏 can be used because it has very short washout time compared to other antiplatelet agent. This relatively short discontinuation window is clinically convenient and it reduces the risk of perioperative bleeding. Let me conclude my talk with this slide. Today, I have shown that several important messages to you. First, antiplatelet agent remains essential in high cardiovascular risk patients to prevent vascular complication, in addition to lipid-lowering medications. In primary prevention, unfortunately, aspirin's benefit is uncertain. especially in a patient with diabetes due to its high-risk bleeding event. Instead, 𝗕𝗏𝗪𝗏𝗃 can offer a unique combination of antiplatelet efficacy, vasodilatory effect, lipid-lowering efficacy, and plaque stabilizing effect with less bleeding risk. So accumulating evidence strongly recommend 𝗕𝗏𝗪𝗏𝗃 as an ideal option for cardiovascular prevention in patients with diabetes. This is all for today. Thank you for your listening.
Thank you, Professor Su, for your wonderful presentation. I think we have about 50 minutes time left. So if there's any question, discussions, you're welcome. Professor 𝗕𝗏𝗪𝗏𝗃.
Yeah. Thank you very much. First of all, I would like to thank Professor Leilani for coming to Myanmar at this difficult time in person. And you have once give us online lectures on the pre-IGD. It's very interesting. And your lecture actually is wonderful and very insightful. I will really thank. A friend in need is a friend indeed. So you come to us here in person. For that, I show my thanks from the bottom of my heart. And your lecture is very insightful, actually. And I've been involved in the prevention of diabetes at the global level. I mean, when I was in World Health Organization. So we talk about preventive diabetology. We talk about prevention. So according to your presentation, we've been focusing only on the pre-diabetes as defined by IFG and IGD. And even among the IFG, those IFG with IGD are only paid attention. IFG without IGD is not much important. And the International Diabetes Federation this year recommendation include 1 hour postprandial glucose as a better recommendation for the screening. And if the 1 hour is more than 153, then this is dangerous, they said. And then if 1 hour is more than 220, then this is diagnostic for the diabetes. So 2 hour postprandial instead of 2 hours, they are now recommending the 1 hour. But however, my question here is that when you set the pre-IGD, and according to our traditional thinking, IFG plus IGD is more dangerous. It is more prone to develop diabetes. And what about IFG plus pre-IGD? Have you ever had a study? Those people with IFG, if they have, in addition to IFG, if they have a pre-IGD, are they, would you think, or do you have any study, they are more prone to develop diabetes? Because we need to make an intervention starting from that period. That is the first question. Second question is regarding the management. If we identify pre-IGD, there should be a pharmacology, in addition to the healthy lifestyle, a pharmacological intervention. Would you recommend metformin? Or if you have recommend metformin, so how many, what is the dose? What is the dose of metformin in that pre-IGD who are prone to develop? And the third question, I just want to know, you mentioned about the C-peptide. Usually we measure a C-peptide in fasting state, fasting C-peptide. And then you also mentioned about the insulin, 2 hour postprandial insulin. So that is, usually we measure fasting C-peptide and fasting insulin level. But according to your study, C-peptide, is it 2 hour postprandial or is it fasting. But for the insulin, you have mentioned that insulin resistance is related to the 2-hour postprandial insulin level. So in that case, we need to fast for the CP, and then we need to measure for the 2-hour insulin. That is my understanding. Please correct me if I'm wrong. Anyway, thank you very much.
Thank you very much, Professor, for a very, very comprehensive questions and comment. First, the question of Professor is, do we have to do pre-IGT tests in an IGT at the same time? What are the, isn't it that the IGT and pre-IGT subjects, from now on, do not be confused, because when you talk about IGT, it's blood sugar. Blood sugar. We know already. But when we talk about pre-IGT, it's insulin level, because the blood sugar in pre-IGT is normal, sir. So if you are already catching individuals on IGT, that's already the start of a decompensated pancreatic function. The pancreas is already fatigued because blood sugar is already increased. You're late. We are late already. That's the first answer. Did I answer that correctly, sir? You cannot test because when the patient is RGT, they are already late. Pancreas is already fatigued. But when you are in the pre-IGT, you're catching up to the healthy fighting pancreas because the insulin is already coming out in a very large amount, normalizing the blood sugar. So as long as your blood sugar is still normal and there is high insulin, catch it up. Put a lot of attacher, which is metformin or glidazones, and lifestyle. I've shown you, so I'm answering question number 3, how will you manage? I've shown you the schematic representation of IGT being managed with metformin and lifestyle. In 30 years, there's a decrease in the 20% developing into type 2 diabetes, okay? So when you probably, not yet, but if you start your patient's treatment in the pre-IGT level where sugar is still normal, it's just insulin that is high, and you start metformin attaching all those insulins into your peripheral tissue, probably the development of overt diabetes will come down in 30 years. So the treatment is lifetime, because lifetime if the risk factor is addressed. Obesity, I don't know how many of the people or our patients can be brought down to ideal body weight, probably none. So if there is risk factor ongoing, lifetime metformin, 1,000 to 2,000 a day, lifetime, and or glitazone, and then lifestyle. That's the answer for number 3. For number 2, I think I have practically answered the 3 because the treatment for pre-IGT is lifestyle and pharmacology of metformin, 1,000 to 2,000 a day, lifetime. What is the monitoring parameter if you are successful, 𝗔𝗶𝗯𝐶? I check my patients' 𝗔𝗶𝗯𝐶 every 3 to 4 months, and if I keep them below 5.7, 5.5, I'm actually successful in controlling the insulin resistance because the 𝗔𝗶𝗯𝐶 is directly correlating with the 𝗔𝗶𝗯𝐶, insulin resistance. So you're controlling the blood sugar at the same time because you are making the insulin sensitivity increase with your insulin sensitizer. Did I answer that right, sir?
What about the insulin measuring and the C-peptide?
The C-peptide, equimolar, they are equimolar. They have the same amount, they are the same.
I mean, when should we, is it fasting or is it postprandial?
I'd rather challenge the system with OGTT rather than in the basal state of fasting. Because all of us may have different fasting state, basal state, all of us, different amount of stress, different body, different condition in the house. But if you stimulate, it's standardized. So I'd rather get a second hour OGTT insulin level. I don't do C-peptide because it's very expensive. It's not readily available, whereas insulin is readily available all over the country in the Philippines. So I go for an stimulated. In endocrine, it should be stimulated rather than the basal.
Right. Thank you very much.
Thank you, sir.
To Professor Su.
Yeah, Professor Su.
Yes.
One question for Professor Su.
Hi. Good morning, Professor Su.
Thank you.
Did you hear me?
Yes, very clearly. Thank you for having me today.
Yes. I'm very much interested in the 𝗕𝗲𝗄𝗧. I noticed that the mechanism involved increase in the nitric oxide. Am I right?
Yes.
Leading to
Yes.
the dilatation. Some of the diabetes patient, they have a complication of the vascular as well as neuropathy and leading to the erectile dysfunctions. So some of them, and most of them, they are using the 𝗕𝗏𝗄𝗏 or 𝗕𝗏𝗏 for the erectile dysfunction. And are there any, my question is, because 𝗕𝗏𝗄𝗧 can increase the nitric oxide and then validation and the 𝗕𝗏𝗏, is there any interaction between the 𝗕𝗏𝗏 or 𝗕𝗏𝗏 with the 𝗕𝗏𝗄𝗧, causing the abrupt fall in the blood pressure, leading to some cardiac events? You get my point?
Yes, that's very important question. So, because it is related to the safety of our patient. So, as you know, the sildenafil or tadalafil is PDE5 inhibitor, which is associated with the vasodilation in important organ in the man. But this drug, the 𝗕𝗏𝗄𝗧, is PDE3 inhibitor. But this drug also have the vasodilating property through nitric oxide production. So if we use both together, it increases the chance of blood pressure lowering. So we have to be careful, particularly in patient with the elderly patient with vascular problem. So I don't recommend to use both the PDE3 inhibitor 𝗕𝗏𝗄𝗧 and PDE5 inhibitor sildenafil or tadalafil together.
Thank you very much.
Professor 𝗕𝗏𝗍𝗍
Just want to like to thanks and appreciate very much for your presence here to give the knowledge that you open the eye of our colleagues. Diabetes start with the pre-IGT stage, with the hyperinsulinemia stage, which we need to aware in our daily practice. So this is a big change to our practice. For me, since I met you before, in my daily practice, I used to test the pre-IGT, test a 2-hour OGTT with the insulin at 2 hours, to the siblings or to the children of the patients. The target patient come to me and I screen the pre-IGT for them. So we found a significant number, and what we do is we do the lifestyle coaching and counseling to these people, and then we assess later. Some fail to follow up, but we can catch some. So it's make a significant change in insulin level. That's what information I'm giving.
Thank you very much, Dr. Momota. I think will you be short with your question, correct?
Thank you very much, Professor Leilani, for coming and sharing your experience. We were very interested in your pre-IGT lecture online 2 years ago. My question is, our people are very high risk of diabetes, and when they come to consult us, they were obesity, grade 1 hypertension, and also ultrasound taking show the fatty liver So I would like to know which people should take C-pep fasting and stimulated C-peptide level or insulin level. So would you share me your inclusion criteria for your study? And another question is, now 1 hour postprandial test for the diabetes is more and more common. So you are doing so many public health study. Is it possible to do 1 hour postprandial test for public health diabetes study? Thank you very much.
Thank you very much for the interesting question, Doctor. First, the question is, when do we do 1 hour and 1 hour for the OGTT? Yes. The OGTT is very important. I do not do fasting, sir. I do not test fasting at all. If the patient is obese, there are fat cells all over the body, and the second hour could be successful. And if there is fatty liver, I think the obesity goes there and the other parts of the body. So stimulated OGTT is better for insulin test. Second is the 1 hour. I have not, in my entire practice, don't have experience on taking the 1 hour. I still stick to 2 hours because a lot of the researches and the guidelines are based on the second hour test for blood sugar.
Thank you very much. And I think Professor Zodanto, please be short.
Thank you, Leilani. I got one question for each speaker. First to Prof. Leilani. If the patient with a pre-IGT is morbidly obese, is GLP-1 will be useful to bring down the insulin resistance, or should they receive metformin or pioglitazone to tackle the insulin resistance?
Both. They have to be treated right away because obesity cannot be 24-hour overnight resolved. So you have to start the patient already with metformin, and then pharmacologic adjustment can be done as their weight improves. Just monitor the 𝗵𝗵𝗋 because you might be late in treating them and they can go directly into overt type 2 diabetes. So weight and pharmacologic. Thank you.
Professor Zodanto, you'll be there.
Thank you, both speakers.
Another question, please.
Sorry.
Thank you. I got a question for Prof. Ling. For the diabetes patient with proven CVT, is there any role of silistazole for secondary prevention?
That's a very good question too. So actually, there are several data supporting the role of silistazole in secondary prevention for patients with cerebral vascular disease, stroke. So there are strong and robust evidence supporting the use of silistazole for those patients, but not that much in patients with cardiovascular disease. As you know, the 𝗕𝗏𝗄𝐺 has a lot of data for those patients for the secondary prevention of ischemic heart disease. But when it comes to peripheral artery disease, there is also strong evidence for silistazole, suggesting silistazole use over other antiplatelet agents. There are subtle differences. So in brief, the cerebrovascular event or peripheral artery event for the second prevention, I strongly recommend the use of silistazole. But for heart, so far, the evidence suggests the use of 𝗕𝗏𝗄𝐺.
Thank you.
Professor Zodanto.
Yeah, thank you for speakers for the wonderful presentations. May I ask one question to the Professor So? As a general physician, we are enlightened by your study had to the study of aspirin and the 𝗕𝗏𝗃𝗀 in the effect of coronary artery disease. Those are diabetes. But if I remember correctly, in your baseline characteristics, both hs-CRP are, I have to say, it is below the low risk, low cardiovascular risk group. So I wonder, but the effect is quite okay. 𝗕𝗏𝗃𝗀 is better than aspirin. But what I want to know is, do you have any study with moderate to high cardiovascular risk as indicated by the high hs-CRP? Is there any difference between aspirin and your 𝗕𝗏𝗃𝗀? There's one question. The second question is, in line with Professor Tirnswelat, I think we tend to use the nitrates for those cardiovascular disease with ischemic heart disease. And the 𝗕𝗏𝗃𝗀 has a common side effect headache, which is attributable to your increased nitric oxide production. So I'm just wondering, do you have any clinical application of these scientific effects to convince that 𝗕𝗏𝗃𝗀 is better than aspirin? Thank you.
Both questions are very, very excellent. So thank you for your asking. Then when it comes to the first question about high sensitive CRP, actually, as you know, the many Asian patients with even diabetes has relatively low level of hs-CRP compared to the Western counterpart, because it is related to the body skeleton size and BMI and obesity. So it is relatively not easy to recruit patients with high hs-CRP. But I strongly agree with you. If we can recruit patients with high hs-CRP, I firmly believe the efficacy of 𝗕𝗏𝗃𝗀 might be stronger than those without the high hs-CRP. So because, as you mentioned, high sensitive CRP is a strong biomarker suggesting high risk of the cardiovascular event. And then the second question is there are a couple of evidence nitrate or other agent effective for reducing the cardiovascular events such as myocardial infarction or ischemic stroke. But there are the recent data support addition to those antiplatelet agent or other vascular modulating drugs such as nitrate or aspirin, we can add the 𝗕𝗏𝗃𝗀. So we can correlate the dual antiplatelet agent such as DAPT, or sometimes triple antiplatelet agent, which is called TAPT. So according to recent data, DAPT or TAPT was the more favorable effect in reducing second attack of myocardial infarction or stroke. So if it is available or possible, I recommend to use both or sometimes triple antiplatelet agent, but it should be maintained just for 6 months or less than 6 months, not forever. That's my answer.
Thank you very much. I think we are running short of time, and tea break about to be ready. So allow me to conclude this session. Before I conclude, what I will say is diabetes, in fact, as you know, is very important. I learned a lot of pre-diabetes from Professor Tirnswelat as we go on coughing, which takes about 5 hours from him and from Professor Kim Maung. So one thing I would like to tell is this diabetes, although you call it diabetes, it destroys all the vessels of the body. From the brain, many stroke patients are diabetic. Many of the coronary obstructions are diabetic. Many of the heart disease patients are diabetic because even without heart attack, the heart is working in an acid environment of ketoacidosis and all. So the heart itself, even without any coronary, it's not normal. And all the vessels in the abdominal and all. And one thing, we have been using 𝗕𝗏𝗃𝗀 for many years, and it's a wonderful drug. If you use cholesterol in time, it can make the patient walk longer distance. And for the sake of the heart, I think I still have a very limited experience of using these, apart from that word, antiplatelet as 𝗕𝗏𝗏 and aspirin. I think they were the mainstay at the moment. So I think in general, we have to be very careful of the pre-diabetics, like Professor has said, and we're very happy that we learned a lot from Professor Su about the asking of about 𝗕𝗏𝗏𝗏 and sildenafil, and all these inhibitors are quite different. So with that, I think I have to conclude this session because tea time is very near. And finally, I would like to thank our speakers, Professor Su and Professor Leilani, for their very wonderful talk and very informative, and also to the Otsuka, a pharmaceutical from Japan, who sponsored this session, and the wonderful discussions and the performance. Thank you very much.
Thank you.